All right, and so without further ado, we want to meet our guest today, Julia Rodriguez O'Donnell. So thank you so much for being here. Given the times, I'm going to give you an elbow bump there instead of a handshake.
That's right.
But thank you so much for being with
Absolutely.
us today, for meeting the needs of undocumented patients with cancer. So let's see what we know about you. Licensed social worker and certified oncology social worker at UNC's Lineberger Comprehensive Cancer Center, and provided psychosocial support and case management to adults with cancer and their families in outpatient clinics.
Correct.
And stop me if I've got anything wrong.
No, you got it.
Okay, over 20 years of experience providing mental health services in a variety of settings, with 10 of those being in medical clinics and hospitals. And working, your bilinguals, English and Spanish, work directly with undocumented immigrants for the past 14 years, as well as immigrants in the application process for asylum, deportation stays, U visas, and legal permanent residency.
Right.
And what's one other thing we should know about you? That's an impressive resume. But what's something outside of that we should know about?
Something sort of fun. I'm remodeling a kitchen right now, doing most of the work myself.
Good
so
for you.
That's been a lot of YouTube videos and new power tools.
Wow, good for you. And this is not your first time. We were talking earlier, and you said this is your...
This is my third kitchen.
Oh my gosh. So,
over a 20-year period.
so we know you have a lot of patience.
Yes, I do.
Okay. Well, we are so glad to have you here today. I just want to preview our first question, and this is kind of a softball. We always make this first question easy, just to get our audience using Poll Everywhere. Undocumented patients with cancer have access to all the same resources as do legal resident patients with cancer. And you can put A for true or B for false. One of those answers, I think we could just wrap up the lecture, and we wouldn't need it, but unfortunately I'm guessing it's the other. While you're thinking about that, and you'll be able to, you can actually go ahead and answer that now, but I will say this activity has been planned and implemented under the sole supervision of the course directors in association with the UNC Office of Continuing Professional Development. William A. Wood, MD, Masters and MPH, and CPD staff have no relevant financial relationships with commercial interests as defined by the ACCME. Julia Rodriguez O'Donnell, LCSW, and OSWC has no financial relationships with commercial interests as defined by the ACCME. All right, so here is our poll, and let me go ahead and change that so we can see the results that are coming in. There we go.
All right,
so
everyone got that right.
They got it right, so you're in the right place, and ready to learn lots more about this topic. So without further ado, meeting the needs of undocumented patients with cancer in North Carolina. Let me pass on the keyboard and the mouse if you would like to use that as a cursor.
Great. Thank you so much for joining us today. And to start us off, I would like to give my disclosure that I have no disclosures to give and have not received any speaker's fee for this activity. So today we'll be looking at three main objectives: the barriers experienced by undocumented and non-English speaking patients seeking cancer care, especially in North Carolina, and the ethical and practical concerns that we experience as care providers, trying to give them best practice care both to our undocumented patients and their families. We'll also be discussing UNC Medical Center and North Carolina community resources that we can draw upon to assist our undocumented patients and their families to receive the best care. So we know that the dialogue around undocumented individuals in our country right now is very politicized, and it's important to start off with just understanding who are we talking about? Who are the undocumented? Essentially, it is those individuals living in the United States without legal permission. They may have come to the U.S. fleeing extreme poverty and seeking employment. They may have fled their home country due to imminent threats of violence from criminal gangs, sociopolitical groups, domestic violence perpetrators, and they may or may not have the legal resources, the financial resources to hire an immigration attorney. And we'll be talking more about resources that they can access. But so some of them are trying to get documented by applying for asylum and U visas and T visas, and others don't have a means to file and become documented. They may have been living in the United States for many years, even decades, or they may be a relative newcomer. They may have overstayed a travel or a student visa and are now living as undocumented. And they may also be living in a mixed status household, which means that they're living with family members who are legal permanent residents or who have gained asylum or who may be U.S. citizens. So I'd like to present our first polling question. True or false? 71%. I was actually going to let you do this, Tim.
Oh, it doesn't matter? So sure, 71% of the undocumented individuals in North Carolina are uninsured. So if you believe that's true, let's go ahead and give it an A. And if you believe that's false, let's give it a B. And we'll give you 10 or 15 seconds. And just we want to assure you that all of our polling is anonymous. So even if you're not sure about the answer, just go ahead and give it a try, and we'll find out for certain in just a few seconds here what the answer is. All right, Julia, how are they doing?
They're doing very well.
Good.
If you answered, as you did, true, that is correct. And we're going to learn some more now about who the undocumented are specifically in North Carolina. So we have about 321,000 undocumented immigrants, and that's out of about 11.5 million in the country. This data is taken from the Migration Policy Institute, which is also listed in the references, and they have a system where they're using a formula to attribute to U.S. Census Bureau data, and this data is from 2012 to 2016. So we tend, I think, to believe that all of our undocumented immigrants are from Mexico or Central America here in North Carolina, but that's actually not the case. 83% are from Mexico or Central America, 8% are from Asia, and the remaining are from Africa, South America, Europe, Canada, Oceania, and the Caribbean. Of ages 15 and older, 43% reside with children under the age of 18, and of ages 16 and older, 69% are employed, 5% are unemployed, and 26% are out of the labor force, which means they're elderly or they're full-time homemakers with young children in the home, that sort of demographic. 36% of our undocumented immigrants here in North Carolina are actually homeowners, which I find really impressive. And as you all answered correctly, 71% are uninsured. And I think that's a really interesting contrast, that 69% are employed, but 71% are uninsured, which says a lot about the kinds of jobs that they are usually doing and able to obtain. So I'd like to talk now about some of the unique challenges and barriers for our undocumented cancer patients. Obviously, common language and health literacy barriers, and those include not being able to speak English. Nearly half of our undocumented immigrants, 5 years or older, in North Carolina report that they can't speak English well or not at all. And our undocumented patients also tend to have a lot of confusion distinguishing what can be a very disjointed healthcare system where there's primary care versus specialty care versus emergency care. They lack an understanding of the U.S. healthcare system oftentimes, and it can be really frustrating for providers who are often judged on these metrics as to what entry point people have into the healthcare system. And once our undocumented patients enter oncology, they may find a home that they feel comfortable with, and it can be really scary for them to reach outside of that and go to a specialist or go to a primary care clinic to address other health needs. And that's something that we really need to help them a lot with in terms of navigating them into those other systems. Undocumented patients are also really likely to be fearful of accessing not only medical care but also psychosocial care. They fear being targeted by U.S. Immigration and Customs Enforcement, also known as ICE, or having problems with their immigration applications for later on for a green card or for asylum or other legal status. And new federal policies do, in fact, view negatively green card applications where individuals have received non-emergency Medicaid or food stamps or Section 8 vouchers or cash benefits. In fact, recently finalized public charge rule, which some of you may have heard of, indicates that immigrants with medical conditions or who lack a proficiency in English or who live in poverty or amongst others in poverty can have a negative view on their green card applications. And people are very fearful. They typically don't have all the accurate information, but they're fearful. And it's very important for us to reassure them that, for example, the public charge rule really doesn't apply to undocumented immigrants because they're not eligible for any of those programs anyway. And so if later on down the road they're putting in green card applications, there's that public charge rule isn't even going to apply to them. And there's no reason why they can't access other programs that they are eligible for, such as our charity care programs, our pharmacy assistance programs, manufacturer's assistance for chemotherapy and other needed immunotherapy and other needed medications. So this is reassurance, and that we're really going to have to giving them, and we'll talk some more about that. In terms of Medicaid, our undocumented immigrants are only eligible for emergency Medicaid, so they can't get full Medicaid, and yet they will oftentimes fear accessing non-emergency Medicaid. And again, we really have to reassure them that there are no negative repercussions for them around that, nor are there any negative repercussions for them applying for Medicaid for their U.S. citizen children. And that is a huge concern because many of our undocumented immigrants have children who are U.S. citizens who were born here or who have other legal status through asylum or what have you. And whatever they're eligible for is not going to hurt the undocumented parent who helps them get that. And of course, those of us working with children with cancer, this is of tremendous importance. In fact, recently my colleague had a parent of their child with cancer come to her and say, we just went to social services and we canceled her Medicaid because we don't want to have any legal problems. And fortunately, we had all just attended a training from the North Carolina Justice Center, and she was able to reassure them, you do not have to worry about getting Medicaid for your U.S. citizen children. Please go back and reconnect her with Medicaid so that she can get the care she needs and so that you all can get the help you need with transportation and other services that go along with Medicaid. Also want to talk a bit about the Dreamers, those individuals with DACA, which is known as the Deferred Action on Childhood Arrivals Program. And those are our undocumented immigrants that came into the country as young children or as minors, and now they have this, they're actually not undocumented because they have this status, but they're not eligible for Medicaid. They're also not eligible, nor are any of our undocumented immigrants eligible for Obamacare insurance plans, and any information or updates about sort of what people are eligible for or concerns that people have about their status. The North Carolina Justice Center is an excellent resource, and we're going to be talking about them more later, but they have some wonderful fact sheets that in English and in Spanish and lots of things in other languages as well that you can provide to your patients. Our undocumented cancer patients and families also have a lot of transportation barriers. They may have expired driver's licenses. They may be afraid of being pulled over for a minor infraction, and that could lead to being detained by ICE. In fact, that just happened to one of our patients that we'll be talking about later with some examples of patients that we work with here at UNC. And so people are afraid of that, and sometimes they don't want to take unnecessary risks to drive if they don't absolutely have to, and sometimes we have to really encourage them and think outside the box to help them figure out how they can get here in a way that feels safe to them. Undocumented patients also are not eligible for Social Security Disability or SSI. We already talked about they're not eligible for Medicaid, they're not eligible for Medicare even when they're 65 and older, they're not eligible for Obamacare, ACA insurance plans, they're not eligible for food stamps unless they're getting them under the names of their U.S. citizen children or legal permanent status children. They're not eligible for any federal or state government programs except a very few exceptions. Pregnant women, they're eligible for some things, including pregnancy care and WIC and some of those things. And again, their children are eligible, so that's really important to remember. And I say, I also want to really emphasize the piece about disability, because we might be working with patients who've been living and working in our country and paying taxes for many, many years, even decades. They've paid into the system, they've actually paid Social Security tax, but if they become disabled due to cancer, they can't apply. And it's confusing to people, it's confusing to us, and it can be really tragic because they will then have no other source of income if they're unable to work. It's also quite challenging for our undocumented immigrant patients to obtain documents that they need to apply for programs they are eligible for, such as the hospital charity care programs, hospital and clinic charity care programs, pharmacy assistance programs, manufacturer's assistance, because for those programs they need to be able to provide documentation that they live in North Carolina, that they aren't just visiting here, that they work here and so forth. So some of the resources that we can point people to, also even just a photo ID. Some of our undocumented patients actually do not have a photo ID. They come in, they don't have a passport from their country of origin. Either they didn't bring it or it expired a long time ago, so it's not valid and they can't use it. So we rely on consulates, their national consulate, to be able to help them get an updated passport from their country of origin while living here through their consulate. They can also go to, if they have children in the school system, the North Carolina public school system, they can go and get a printout that their child is registered at school and it has the parent's name and address on it. That can be used as a proof. A lot of our undocumented immigrants, they don't necessarily have lease contracts. They may not have utility bills in their name because they may be subletting, they may be living with other people. And so these are some of the creative ways that we try and get proof that they live here and work here and have children in school here and they are eligible for our hospital and clinic and pharmacy-based assistance programs. Also, letters from employers and pay stubs are a really good way to show that. So I'd like to kind of review some of the practical issues just going through a day of appointments that our undocumented patients experience. Starting with registration and check-in, they are likely going to be checking in with someone who probably doesn't speak their native language, and if their English isn't very good, check-in can be challenging. And they may be asked for documents and IDs and things, and they may not really understand what they're being asked for. They may be referred to a financial counselor because they don't have any insurance, and the financial counselor probably won't speak their language. And so lots of times our undocumented immigrant patients, and really any non-English speaking patient, they do their best, right? They throw out a few English words that they know, and they kind of pretend that they know how that they are able to communicate when they may not be able to. And they may be embarrassed to say that they can't. They may be afraid that if they do, they won't get services. So it requires some subtlety to kind of really recognize when, and to ask actually, to just openly make sure that people are understanding us at every point in the process of them going through their care with us. When they check in, let's say they make it through talking with the financial counselor and maybe you're given some forms, they may have a third grade education, they may be completely illiterate in their own native language, much less English. And forms certainly are in Spanish, but they're not in other languages that people may be coming from. And so they're going to really struggle with filling out those forms, and we'll talk later about how we can help them with that. So when they go to check in after that, at their actual clinic where they're seeing their provider or getting a treatment infusion, they'll probably be checked in English. They might have their med review done in English, and again, they're just kind of trying to make it through. And we absolutely must make sure that we're getting interpreters and making sure that they feel comfortable being able to communicate all of their questions and concerns with us. And we'll continue talking about how we can use our interpreting resources to help us with our patients. When they complete their appointment, they're going to check out and schedule their next appointment, which will also be in English, almost certainly, probably. And after visit summaries and prescriptions that they are going to need to take down to the pharmacy to get filled or take to a pharmacy. It's absolutely important that those are in their native language, and we'll talk some more about that. When they get home, if they have questions, if they spike a fever or they don't feel good or they have intractable nausea or vomiting or diarrhea and they need to know what to do, they can't remember, they may have a real challenging time getting a hold of someone to get some urgent medical advice over the phone. And there's some specific things we've done here at UNC to try and address that, and things that I think can be done in other settings to help make sure that patients can get advice that they need. Let's go now to our first clinical example. And these are composite clinical examples that I put together with some creative freedom based on lots of patients that I've worked with. Our first patient is an undocumented female in her late 50s with advanced GI cancer who's covered by the hospital, charity care, and pharmacy assistance programs. Her health status declines rapidly when her undocumented adult daughter and sole caregiver is one day pulled over for a minor traffic infraction and detained by ICE and put in a detention center in another state. All of this happens completely out of the blue. The family's kind of scrambling with, there are some other relatives, but they all work full-time, and they were not her caregiver, and they weren't on top of her medications, and didn't really know what was happening with her treatment. And so it so happens that around the same time, her pharmacy assistance expires, and she's not able to get her medications, and she doesn't know what to do, so she doesn't do anything. And she stops taking her medications, and then she gets very sick and ends up in the hospital with intractable pain and nausea. So not only was she critically ill, but she's devastated that her daughter is now in a detention center out of state. She doesn't have the caregiving support that she needs to return home after her symptoms stabilize in the hospital, but she's not eligible for long-term care Medicaid, and her family can't afford room and board and nursing care in a SNF or other facility. So she stays in the hospital longer than is really needed until she's stable enough to go home with the really suboptimal home caregiving that the family is able to cobble together. So our oncology providers and nurse navigators formulate a letter of medical need to give to the family so that they can try and gain legal assistance to show that this daughter is really vital to the patient's care at home. That was example 1, and now we'll go to example 2. We have an undocumented male in his 30s with B-cell acute lymphoblastic leukemia. He's having disease progression with the available oral chemotherapy medications that he is able to obtain through the manufacturer's assistance program, but he's still progressing. He's not eligible for a bone marrow transplant because the hospital charity care program doesn't cover BMT, nor does emergency Medicaid. He is the sole custodian of 2 minor-age children who are U.S. citizens. Their mother is deceased. And both the oncology provider team and the social worker and nurses really struggle to help him face legal guardianship plans that he desperately needs to make for his daughters, while also supporting the hope that he'll survive as long as possible on this suboptimal oral chemo that's not the best option. If he'd been able to access a BMT, he would have had an excellent prognosis. And our last example is of an African female in her mid-40s who overstayed her student visa many years ago and had been working. So she's now essentially undocumented. She delayed having her breast mass evaluated because she was uninsured and she was fearful of entering the U.S. healthcare system. By the time she comes to the clinic, she has a fungating mass that's diagnosed as stage 3C advanced breast cancer. She's approved for hospital charity care and pharmacy assistance, and I didn't write this, but also manufacturer's assistance to get chemo. She also gets surgery, she gets radiation, she gets subsequent immunotherapy. Over the course of years, she gets absolute state-of-the-art medical care. However, she remains extremely vulnerable psychosocially. She lived alone in a small apartment, having worked previously as an in-home caregiver to elderly individuals with no benefits. She was estranged from her relatives who live in other parts of the country. She became too ill to work, and without any income or any ability to get Social Security disability, she was completely dependent on foundations, her church, and one-time grants to prevent eviction. And so we provided a lot of support. The Nurse Navigator provided a lot of support with grant applications and gas cards and lodging assistance and parking assistance, because she also lived 3 hours away. And yet she misses a lot of treatment appointments due to car breakdowns and lack of bus access. When her illness progressed, she was hospitalized multiple times for acute problems and only accepted home hospice in the final days of her life. When she finally pulled in her relatives, and they spent the last just week or so with her.
All right, and let's take a look at, our next poll question here. And undocumented patients with cancer often avoid advanced planning because of which of the responses below? And let me just make sure we've got this active. We should, yes, we do for our audience. It may, and answer the, it doesn't look like it's quite popping up the way we want it to. I'm going to try and bring that back and see. There we go. Sorry about that. All right. So again, undocumented patients with cancer often avoid advanced planning because of which of the responses below? And if you believe it's A, it may be more difficult for them to face the devastating effects of terminal illness on their families who are already more vulnerable economically and socially due to immigration status. B, it could be perceived negatively as giving up hope because in their home countries the concept of advanced planning may not even exist. Or C, both of the answers.
So, so far we've got 100% C, which is the correct answer.
Great.
And we're going to we're going to delve in now into some of the intensive practical and ethical challenges for our oncology providers and serving undocumented patients with cancer. The stages of cancer and corresponding treatments are challenging for anyone with limited education and psychosocial resources, but it can really be incomprehensible for our undocumented patients. Gaining and maintaining trust is a key component for undocumented patients, and I will say that they share that they've often had experiences in their home country or here being turned away from medical care due to discrimination, and so they come to us more guarded and fearful. So we have a lot of trust building in order to overcome that. I alluded to this earlier, but they may do a lot of nodding and agreeing and smiling, and then later they may not adhere to treatment plans. Rather than asking questions and talking about what their concerns are or getting a better understanding of why we're recommending what we're recommending. And I know that because they oftentimes come around the provider team and will come to an ancillary staff member like someone at the resource center or a social worker or a volunteer and say what those concerns are, and then there's a lot that I think the provider team can do to utilize those of us who are working intensively with our undocumented patients and take advantage of those relationships to help them be willing to bring those questions out into the light and to bring their worries and concerns out into the light. And we're going to be talking about that a lot today. Along the lines of building trust, one of the ways that illness, cancer illness and treatment really affects our undocumented patients uniquely is that they're more likely to have jobs that are lower income without PTO benefits or even without permission to leave work to come to an appointment. And likewise, their caregivers, their family members may not have permission to leave work to bring them to appointments. And so that makes it really hard for them to stop work. And that is not to say all, because we do have some undocumented workers that are working in agricultural settings or chicken food processing plants, pig farms, things of that nature, where they do have some benefits. And so sometimes there are forms, FMLA and short-term disability and things like that. But for the larger percentage of our undocumented patients, that's not available. So, and these are people that they may be the sole provider for their family. They may be the sole child care provider for their family. And they may be much less likely to be willing to do a treatment that is going to mean that they can't work for long periods of time, either because they're too ill or for whatever reason, because it's not logistically possible to do treatment and work. And they may even try working when it's unsafe, and I've certainly seen that, including construction workers, which is a big area of work for our undocumented patients. They're climbing ladders, doing all kinds of things, and they may want to keep doing that. And so lots of conversations with them about what their psychosocial needs are around finances is important. It's also really important to help our undocumented patients understand as fully as possible the difference between curative versus palliative care and the change that occurs when cancer becomes metastatic. It may be more difficult for them to face the devastating effects of a terminal illness on their families, especially when they're already more vulnerable economically and socially due to their immigration status. We referred to this in the polling question. Advanced planning is often avoided, and that's for several reasons. One, it may be perceived as giving up hope, and it really is true that a lot of countries where people are coming from, advanced planning does not exist, and in that way it's a very Western medical concept, and so that it may really just be about everything to move forward with curative intent, and it may be really hard for them to understand that there are other ways to care for them and support them beyond that when cancer becomes metastatic. And these are really important considerations with no easy answers, and a lot of cultural differences that play into it. So I really encourage all of us to just do as much kind of transparent talking with people about that as possible. Other practical and ethical challenges are things like medication. It seems really obvious, but it actually doesn't always happen without patients coming and saying, I can't read this pill bottle. How am I supposed to take this medication? So we have to remember to make sure instructions, pharmacy instructions, are in their native language. And after visit summaries with instructions on what to do if this happens or if that happens, or what was reviewed in the appointment and what decisions were made in their native language. And I'm going to talk in a bit about a way that we do that here at UNC. Primary care is absolutely essential for all of our cancer patients, and it's something that our undocumented patients we may have to really help them get to that, because they find a home with us. This may have been their entrance into the medical care system at all when they were diagnosed with cancer, and they didn't go to the doctor before that, and now they have blood sugar issues or full-blown diabetes, or they develop other issues, or they need dental care. And as we know, dental care is not easily accessible for uninsured individuals, and so they need a lot of help connecting to these other clinics and programs. I'll also say that when it comes to patients coming in with questions, calling in with questions for their medical team, that they oftentimes they don't pick up their phone when people call them back, especially from a number they don't recognize, because they're afraid of who it's going to be and that they might be targeted somehow for their immigration status. And so again, using ancillary staff members that may have a really close relationship with them, whether it be a social worker or a volunteer or a volunteer staff member or a navigator whose number they recognize, can be a great way to get a hold of them to help them with urgent care issues. Web-based portals such as MyChart are not typically welcomed by our undocumented patients. It's not to say that none of them want to use it, because some of them are very savvy with their smartphones and we can show them how to get connected, but some of them, they're just not accustomed to getting and exchanging information on the internet. So that may not be an option for them. End-of-life care for undocumented patients is very different. And the research and the literature shows, one of my references, Gianmarillo and Huey, 2016, tells us that undocumented patients often receive more aggressive care, including prolonged hospitalizations and hospital deaths and intensive care unit admissions. And access to hospice care for our uninsured patients and undocumented patients is only going to be possible through charity unless patients have the ability to pay, which they probably don't. And so they're left with emergency departments and acute care hospitals as their only recourse. So a difficult decision that comes up at end of life that I have been a part of with numerous patients is whether or not they're going to be able to have the ability to travel towards end of life, to either return to their home country or to go to other parts of the country where they may have relatives living, because a lot of undocumented families are very widely dispersed around the country. They have people in California and Ohio and Florida and Texas, and so even though they have relatives, they're not in the state necessarily. And at end of life, of course, having closeness with relatives and family, not only to help with caregiving, but also just to be together, becomes much more critical. And it can be really difficult and presents a lot of ethical and legal considerations about, are they well enough to travel? What if they die while en route? traveling either to their home country or to another state. And so there's a lot of logistics involved, and we don't really have good data on what proportion of undocumented patients die in the U.S. versus in their homeland, because some people do want to, as they say, go home to be with their relatives back home before passing. And so these are considerations that really have to be made on a case-by-case basis. And I think a lot of our undocumented folks are taken by surprise at end of life as to how acutely ill they've become, and sometimes they wait too long to really think that through. And I think that that's something that we can help them with, is beginning to think about that. And again, it goes to advanced planning, and well, isn't that taking away hope? So, you know, we have to kind of be where they are in that, and yet also trying to help them think through some of the things that they may want. In terms of supporting our undocumented patients in your North Carolina Cancer Center, these are some of the critical things that I think are important: providing language interpretation and translation of medical regimens and after visit summaries and pill bottles. And one of the strategies that we use is that at the end of an appointment, our provider will toss that stuff into Google Translate as a first pass. Then they have the interpreter, either over the phone or the in-clinic interpreter, look through it and make any necessary edits before it gets printed out or sent to the pharmacy for to be put on a medication bottle. So that's a quick way to make that happen more consistently. I think it's really important to connect patients to native speakers whenever possible. Financial counselors, lay navigation counselors, resource staff, social workers. It helps them feel more comfortable and welcomed. Spending time with them to establish rapport and safety. And we talked about this a little bit earlier, but really helping navigate them through the U.S. healthcare system. So it's probably not going to be enough to say, you need to get a primary care doctor. You should do that. Somebody needs to help them figure out, well, is it going to be our family clinic that they can get established with? Is that going to work for them in terms of transportation? Does it need to be one of the federally funded clinics closer to their home? And the federally funded clinics really are the gold mine for our undocumented patients. Sometimes they even have care coordination programs for immigrants, and they help with a lot of resources and medication obtaining and all kinds of things. And of course, they are the only ones obligated to serve the uninsured. And they usually have financial assistance programs that they have somebody there to help patients fill out and get enrolled and so forth. I feel like our oncology nurses and providers are in an excellent position to help patients connect with the sort of boots on the ground folks that can do this navigating, and that includes medical social workers in your oncology team, and financial counselors, and navigators, and folks in the resource center that you may have access to. These are the people that are going to be able to help them fill out forms, obtain documents, help them print things out on the computer, help them make phone calls, help them get appointments, help them, I mean, I've many times had patients calling me while they're trying to find this primary care clinic that we connected them with, and I'm giving them directions on the phone so that they can get to their appointment. I mean, once they feel they can trust us, we really become an important source of navigation for them. Connecting patients with immigration centers and other community resources in their area can be really helpful, and I'll share some of those resources with you. And I believe we are to our third and final polling question.
We are indeed. So a humanitarian visa usually lasts for up to 1 year and therefore is a stable means of gaining legal permission for a patient to remain in the U.S. or for a relative to come here to care for them. And that's a true or false question.
True or false question.
A, true, B, false, and we can go ahead and look at the responses that are coming in. So not quite so clear-cut for our audience this time.
Not so clear-cut, and this is an area that any of us who work with undocumented patients or immigrants who are documented will often be asked for help to get someone into the country to help them. And this is basically called a humanitarian visa. And for those of you who answered in different ways, that's completely understandable, because humanitarian visas are not really well understood. So I'm going to try and help you understand them a little bit better. They typically only last for 14 to 30 days. So it's definitely a quick Band-Aid and not a longer term solution. So it is, let's see, how did I word the question again? It is not a stable means, so this is false, right? And but it can be an incredible short-term help. And so what happens is patients come to us, or their family members come and say, one of two things. We want to bring someone here that lives in our home country, and they can't get a visa, a tourist visa. Can you write a letter? And these letters, a lot of people I think are intimidated by this request, but it's actually not intimidating. I don't want it to be intimidating at all. Sorry, forgot to switch slides.
Oh no, and I just want to mention very quickly that I'll go ahead and switch poll everywhere over to where our audience can go ahead and ask questions now.
Oh,
so,
good. Yes.
I'm sure many of you have questions already.
Perfect.
You can go ahead and submit those in just a second, and then we'll be ready for those at the end.
Okay, good, thanks. All right, so the other reason our undocumented patients or family members may ask for a letter is because the patient is needing help to prevent deportation, or they've got a court hearing for their asylum case, and they need a medical letter from us stating this is the diagnosis, this is the care they're getting, this is why it's really important that they be here, so that they can stay in the country and keep getting their medical care. So the letter from the medical doctor or provider team needs to state their diagnosis, the treatment modalities, the prognosis and duration of treatment. It needs to address that it needs to say, you know, this patient is receiving their care through the hospital and pharmacy financial assistance programs, and they don't have access to any other insurance, and so that's why it's absolutely vital that they be here. And they certainly, you know, they couldn't get their care back home. And then also why that patient needs a family member to come, so to address the caregiving need. You know, this person needs a caregiver for these reasons, and that's why they're asking for help from a relative, because they don't have people here that can provide that care for them. So those are the sorts of things. This reference to U.S. Citizenship and Immigration Services website, that's where I took this from, and that is in the list of references as well, and you can use that as a resource if you have further questions about this process for our patients. So in our last minutes, we have about 8 or 9 minutes, I want to take questions, and I also want to review some of the resources here in North Carolina and in the U.S. That we can help connect our undocumented patients to. North Carolina Justice Center is excellent. I talked about that. The Hastings Center Project for Undocumented Immigrants and Access to Health Care is a database that includes a selection of recent literature on the emerging health consequences of immigration enforcement as it affects lawfully present immigrants and asylum seekers and citizens in mixed status households. And that link is there. We talked about federally funded primary care clinics that are hugely important for our undocumented patients. It's where they're going to get dental care, primary care, diabetes medicine, high blood pressure medicine. It's where they're going to go if they get a toe fungus infection. Instead of calling us, true story, that one of our oncologists was asked by our undocumented patient, can you please treat my toe fungus? Because they were afraid to go to another clinic, a primary care clinic. But we helped connect them. And those are the kind of things that they need primary care for. Catholic charities and local churches are a wonderful resource for our undocumented patients. And they are located throughout the state, and these links will get you to them. And they have legal resources related to immigration, counseling, social services, food resources, all kinds of things. second page of resources that I have for you. El Futuro in Durham is a mental health center with bilingual providers in Spanish and English for uninsured patients, offer sliding scale, and also Medicaid recipients. CWS Durham in Triangle provides multiple services to refugees and immigrants from all over the world, from all countries. North Carolina African Services Coalition provides low-cost immigration legal assistance to any individual or family that needs it. U.S. Committee for Refugees and Immigrants, North Carolina chapter. Our nation-based consulates, so if you got somebody from Guatemala and they need a consulate because they need a Guatemalan passport, you can hit this link and you can find where their closest consulate is. The North Carolina Council of Churches has a fantastic list of dozens and dozens of resources for immigrants through this link, and of course ACLU of North Carolina. So I think I'd like to turn it over to any questions.
All right, great. Well, while we're waiting for some to come in,
Okay.
and let me see, I don't have any in yet,
Okay.
so I definitely have some. This is, it's so challenging to have a cancer diagnosis, so challenging to navigate an undocumented status, and putting the two together, it's just hard to imagine the sort of exponential challenges that combined those present.
Right.
You were talking about language. I did want to just a quick mention, a quick shout out that we recently in September had a lecture on working with LEP patients, limited English proficiency patients, and medical interpreters. So
Yeah.
I do want to point folks in that direction if they're interested in more about that topic. What are some of the strategies as far as language? So I can imagine just receiving a cancer diagnosis in your native language can be hard enough to hear.
Yeah.
Are there things that can help somebody who has limited English proficiency in that circumstance?
Yeah, absolutely. I think the first thing that patients need a lot of reassurance about is that cancer does not equal death, because of their limited language literacy, but also health literacy.
Right.
They equate those two things very frequently. And so really being able to reassure people that there are treatments, that there are many things that we can do to help them, and also giving them some language, giving them some terms, simple terms like cancer has spread to these organs, or cancer is in your blood, or what lymph nodes are and what the lymph system is, fluid that carries your immunity. Simple concepts that can help people understand how cancer is affecting them, and also how cancer is not affecting them. For example, I recently had an undocumented patient who thought because she was in cancer treatment, she could not go outside or go on walks.
Oh, okay.
And we didn't know that right away. She was like holding herself up inside. And once we learned that, we were able to say, no, going for walks outside, if you feel up to it, that's really good for you. So really working to kind of uncover any myths they may have about what cancer means, and then making sure that we give them the information so that they can take good care of themselves. They may have a lot of nutrition questions. What kind of foods? Can I still eat my spicy food? Can I? All of that. And so there's lots of things we can do to help with that.
Okay, that makes sense. And I'm guessing, in the same, talking with anyone with a cancer diagnosis, you're really going beyond just looking for a nod or a yes or no. And I'm guessing that again, that's real. You're doing a lot of that checking for understanding. Tell me what you heard. Sorts
kind of the
questions.
Back.
Right. And I'm guessing that's especially applicable in situations
really
with patients
is.
with limited English proficiency.
Yeah, definitely.
Let's see. We do have a question that just came in. Let me go ahead and put that up on the board here. And it's being a little slow, but we should see it, but I can see it here. SSI, SSDI is requiring the Social Security number of patients on applications for documented children. Any way around this?
Okay, let me make sure I understand. SSI applications for children is requiring the Social Security number of their parents. Okay. It's a great question. Many of our parents are working, and so while they may not have a social security number, they probably have a tax ID number. And a lot of times that can be used in lieu of a social. So that's what I would recommend. That's my first thought. And this is actually something I didn't know, so I'll do a little bit more digging into this. But definitely, if they've ever filed taxes, they have a tax ID number. And that's a federally provided identification number that these folks are using, and I think that that would suffice. If neither of the child's parents have worked, I actually don't have the answer to that, and I think it's something that I need to do some more research around. So great question.
All right. Well, thank you. And we are nearing the end of the hour, so we appreciate that question. We appreciate all the responses to Poll Everywhere. Just a few things that I want to mention in wrapping up. We want to say thank you, thank you, thank you. We want to thank the North Carolina General Assembly for their generous support of this program through the University Cancer Research Fund. We want to say thank you to the UNC Lineberger Comprehensive Cancer Center.
Definitely.
We want to say thank you to the UNC Cancer Network team, Mary King, Veneranda Obore, and John Powell. Thanks for all the hard work that you do for each and every one of these lectures.
Thank you.